Uh, Next question. A 66-year-old man presents to the hospital with palpitations. An ECG taken shows atrial fibrillation. He has no history of any ischemic heart disease. His blood pressure is 110 on 70 millimeter Hg. His heart rate is 130 beats per minute and respiratory rate is 20 breaths per minute. He looks sweaty on examination. His chest is clear clinically on auscultation. What is the single most appropriate management? The patient is stable, but he has tachycardia. Okay, and the first choice will be okay. A. Adenosine. B. Metoprolol. E. Electrocardioversion. D. Amiodarone. E. Digoxin. As we said, the patient is hemodynamically stable, but the patient has tachycardia, and our first choice will be metoprolol. Explanation: rate control medications such as metoprolol should be given first as he is hemodynamically stable, as we mentioned above. If rate control medications fail, then we could try rhythm control medications. Note: digoxin as part of rate control should not be used as first line unless there is evidence of congestive heart failure. Okay? If the patient has congestive heart failure on auscultation, we should use digoxins as part of our control at first line. Remember, the most important part of management for atrial fibrillation is preventing strokes and controlling patient symptoms. Converting patients back to sinus rhythm is not always the main goal. Okay, atrial fibrillation management. The clinical presentation of atrial fibrillations are different. Some patients are symptomatic, others may have life-threatening complications like heart failure or angina. The management depends on the underlying cause and the presence of symptoms. There are two main categories for management: rhythm control and rate control. If the patient has signs of shock, syncope, acute cardiac failure, or ischemia, then perform electrocardioversion under sedation. But this is rarely necessary. There is also the option of chemical cardioverting with flecainide or amiodarone. It is better to choose first chemical cardioverting with flecainide or amiodarone, but if there is no any answer, we can use electrical cardioversion. If the patient has had symptoms for more than 48 hours, and it's important, more than 48 hours, there is a risk of cardiac thromboembolism when cardioverted. When we want to cardiovert the patient, we must think about the time. If it's more than 40 hours, there is a risk of thromboembolism. So in these cases, rate control medications and low molecular weight heparin are better choices. Rate control. Rate control medications include beta blockers like metoprolol, rate limiting calcium channel blockers like diltiazem or verapamil, and digoxin. For rate control, beta blockers or rate limiting calcium channel blockers are first choice, unless, as we mentioned above, unless the patient has congestive heart failure. Digoxin 500 mcg is usually the choice of drug if the patient suffers from congestive heart failure. Example of how rate control is performed. Either a beta blocker like metoprolol 2.5 mg up to 5 mg IV every 5 minutes, which can be repeated in intervals of 10 minutes to a maximum of 10 mg, or 50 mg orally, or a rate limiting calcium channel blockers like verapamil 2.5 mg IV every 2 minutes, which can be repeated in intervals of 5 minutes to a maximum dose of 10 mg, but not both. We should not use both. We should use one of them, or beta blocker or calcium channel blockers. Second, if rate does not fall sufficiently, we should add digoxins. Third, where heart failure is a clinical issue, we should start with digoxins. And fourth, also, we should give thromboprophylaxis. As we said, if the patient is more than 48 hours, we should give thromboprophylaxis. Persistent AF is considered AF that is not self-terminating and lasting longer than 7 days or prior cardioversion. This is generally idea of when we should use rhythm control and rate control. Factors towards rhythm control first for patients with persistent AF. Patients who are symptomatic, patients who are younger, and patients presenting for the first time with lone AF. And factors towards rate control first for patients with persistent AF. Patients who are over 65-year-old age, if patient is stable and AF started more than 48 hours ago, and patients who are unstable for cardioversion, such as a long history of AF, usually more than 12 months, and patients with a history of multiple failed attempts at cardioversion or relapses.